Hi everyone, and welcome to this webinar on Shockwave, translating research into practice for the lower limb. I'm Katie and I am the Training Education Manager at PhysiQuip. And for those who don't know PhysiQuip, we are a medical technology distributor based in the UK, specialising in rehabilitation technologies, including diagnostic ultrasound, focused shockwave and lymph touch. So this evening, I'm very delighted to be joined by my colleague and clinical application specialist, Dominic Smith, or our very own in-house shockwave guru. Give me a bit of credit there.
Pressure as well, Katie, thank you.
So following Dom's presentation this evening, we will do a Q&A session, including a few of your pre-submitted questions, so thank you for those. So if you'd like to submit a question during today's session at any point, please use the Q&A function at the bottom of your screen and we can address them towards the end. So on that note, I'm going to hand over to Dom for the presentation.
Thank you very much, Katie. As you say, my name is Dominic Smith. I'm the clinical application specialist at PhysiQuip. With a keen interest in Shockwave. Been working in the sector now for 4 years, or working with Shockwave for the last 4 years now. So hopefully we'll get some nuggets of information as we go through this presentation and answer a few of your questions at the end. So yeah, we're going to look at translating research into practice for the lower limb, which builds on the one we did last year of the upper limb. So it'll be quite interesting to look at what we go on this webinar. So during this, what we're going to have a look at is a very, very quick overview of Shockwave and what Shockwave is, if you're not familiar with it, and the different variations. We're going to look at some of the indications for use in the lower limb, and then we're going to look into some of the research of the common lower limb indications and how we can transfer what we see in those research papers into clinical application and practice. Obviously, we're going to give you a taste. It's not going to go too in depth. Obviously, we have a couple of heavy slides, but hopefully it'll give you a good idea of how we can pull some of this information and put it into practice. A few disclosures to start off with. Obviously, PhysiQuip represent the Richard Wolf focused shockwave system, the PiezoWave 2. I want to be very specific here. The information that we present is not specific to the PiezoWave 2 or the comparative technologies. It's just looking at focused shockwave in general. And the papers that were selected are the ones that we feel best represent each subject discussed. So there might be other papers available. We just sort of pick some of the ones that we feel have a good representation. And it's very clear this isn't product training for anything. It's a review of the research, the evidence available, and how we can transfer that into practice. And if you've got any particular questions around a device, then we recommend you go and speak to the relevant manufacturer or local representative so that you get information that's specific to that device. So with that said, a little bit of background about Shockwave, what it is. So it was used around 4 decades ago to disintegrate urinary stones. So we might be familiar with lithotripsy, breaking up kidney stones, that kind of thing. From that point, it was really developed in that MSK field, so actually looking at bone initially, and then it moved into that tendinopathy space. For those who aren't aware, focused shockwave became first, radial was the offshoot from that. And from that point, everything's been very successful from there in terms of clinical outcome. There's plenty of evidence out there that supports shockwave therapy that is safe and effective for using on several MSK disorders. Although as we go into it, the evidence and the research can be quite conflicting in some areas. It's quite an interesting discussion to be had. So just so we're familiar with what a shockwave is, it's a strong pressure wave in any elastic medium, such as air, water, or solid substance that creates violent changes in pressure. It's an abrupt, nearly discontinuous change, and it's very different in terms of typical sound waves. There's a compressive wave at the front, which creates a sudden change in stress and density and temperature. For those who want to actually see a shock wave, I highly recommend having a look at the satellite pictures of the Tonga volcano. Interestingly, I found it quite interesting. The shock wave went around the globe. I think it was 4 times they recorded it. It's how powerful it was. So it's I just find it fascinating that we actually have that in therapy. But as you see the volcano erupt, you can actually see the shock wave coming out. It's a nice visual representation of the changes in pressure that you see there. So types of shockwave that we have in the medical world. We have focused shockwave and radial pressure wave, also known as radial shockwave. And they are fundamentally different. They do produce different pressure waveforms. And the impact of that is that you have different effects on tissues depending on the waveform and the pressures that they produce. We're not going to go into that too much. That is a topic for another day. And it might come up in the questions at the end, but it's worth noting that they are fundamentally two different types and will have a different effect on tissues. There is a conversation to be had about focused and radial, how they may complement each other. And we have seen it work in complements in sports practice, sports clubs, and also private clinics. From what I've seen, I haven't seen many papers that actually look at how they could be used in conjunction. A lot of them actually compare. So there's not much in terms of what I've seen of how they could be used together, apart from anecdotal clinical evidence. But just to give you a nice visualization of the differences between the two. So on radial, where you have on the left here, you have an impacts the surface of the skin, and the energy disperses out into the tissues. So your maximum energy is at the surface of the skin. As it travels, there is an equation, I can't quite remember off the top of my head, but as it goes down each centimetre, you lose a particular percentage of energy. So beyond really 2 to 3 centimetres, the energy that you're delivering is not really travelling there. Focused is the opposite way. You take all the energy and then you're concentrating it into one point. So all of the only treatment aspect is where that sort of small cigar-shaped, we call a focal zone is. That's your treatment area. So you can be very, very specific. You can bypass all the healthy tissues and just hit the target tissues that you want that is pathological or is in some way injured. So that's one of the major differences. Obviously, one of the other aspects as well is that because focus is more concentrated, the energy levels are much higher. So on average, they're about 8 to 10 times stronger than radial, which has a profound difference on the response in the cell. So looking at applications, there are a few differences here. So just to give you a quick overview, you can see there for radial shockwave, typically you're going to be using it on chronic injuries rather than sort of acute. And then on the focus shockwave side of things, you have more indications for bone as well. Again, that's something we're going to touch on a little bit, but that's a conversation for another time. Obviously, we're going to look at common indications in this webinar. I think there's some really interesting evidence that's coming around ACL, some joint capsule, and some ligaments as well. As you can see there from a radial perspective, you're limited into what you can treat, whereas focus gives you a lot more option. Therefore, it's worth noting that on the acute side of things, it is dependent on the extent of the acute injury. It's typically used to manage pain. So if you've got a full rupture, obviously, common sense, you're not going to be using it on that. But if you've got a slight tweak, like a sprain and overstretch, something where the tissues are irritated but not completely damaged, you can be using focus shockwave to manage the pain, essentially. So let's look at translating some of the research. So again, we're going to look into a couple of papers and how we can pull out the methods into a treatment application, protocol guideline, however you want to call it. But if you're going to look at this into yourself, I've cherry picked a couple of papers, and there is absolutely stacks of papers around tendinopathy particularly. So that's one of the challenges that you'll face. And a lot of it has conflicting outcomes for a multitude of reasons. Some of which we've listed here. So subjective outcome measures is one. Varying inclusion exclusion criteria is very different from paper to paper. Lots of different treatment variables, whether you're looking at hertz, the shockwave frequency, the energy levels that are selected, the frequency of treatments between each. I have seen a few papers where they don't specify what type of shockwave they've used, whether it's radial focused. I've even come across a few that don't even tell you whatsoever. They just say shockwave. So that's not very useful in some. And then obviously as well, you sometimes have a lack of control group as well. So they can be quite difficult to decipher from that perspective. It's worth noting there are some challenges that you may face with that. In terms of what we're looking for, what I look for in these kind of papers, first and foremost, is the technology safe to use for that indication. So have they proven that it's safe and whichever there's no direct contraindication of application. And then what were the parameters of the treatment? So what were the hertz? How was the frequency delivered? What energy levels were they doing? 0.1 millijoules, 0.3 was there a range they used? Frequency of treatment, once every 3 days, 7 days, 10 days. Type of technology used, obviously the follow-ups as well, of looking at how long it was until we saw clinical changes. And then also look at the subject demographics. Some of the papers have quite a wide demographic, some are very, very specific, as there's quite a few things that we need to look at of how we translate the information. But what we're going to do is have a look at a couple of examples. So common indications for shockwaves: Achilles tendon, patella tendon. It's boring because it's the things we always talk about. I think it's a good idea of what we can do with those, and I know there's plenty of papers out there to support these. So looking at Achilles, so according to the anatomical location, we've got two categories: insertional, non-insertional, mid-portion. And we're all familiar with the conservative treatment, pain meds, eccentric exercise, which is the big one. That's probably the go-to aspect with physiotherapy. Could look at injections as well, low-level lasers, radiofrequency treatments. There's a multitude of other things that we've probably not in there as well. So there's plenty of option that we've got to manage these. We're going to look at some research with the Achilles. So here's a quick paper in terms of a double-blind randomized controlled trial. So to compare the effects of conservative treatment with Shockwave to placebo in just under 50 patients. So decent enough group size. Your Shockwave treatment group had 4 lots of 2,000 pulses at weekly sessions. Quite a wide energy range between 0.1 and 0.5 millijoules millimeters squared, and then with conservative treatment on top of that. And then the sham, where they had 2,000 shots, the patient would have heard the noise, but there was no energy getting delivered, whether it's a gel pad blocker or they didn't put in a transfer medium between the two. But they did get, obviously, the control with the eccentric loading and stretching. Results looking at the American Orthopedic Foot and Ankle Society score, and only a 12-week follow-up, so quite a short follow-up. But in the group, we saw an increase, the group saw an increase from 70 points to 88 points over the 12-week period. A pain reduction in both groups, where there was no statistically significant difference, but they did see a better outcome with women. They did conclude it appears to be a viable supplement for the treatment of chronic Achilles tendinopathy. So I think it's quite an interesting paper. I think the wide energy ranges might have resulted in there not being a statistically significant aspect. I would have liked to have looked at if they had Shockwave without eccentric loading and seen if that would have had an impact and given us a bit of a better idea of the differences. I'll just give you an idea on one there. And then another one which I think was a little bit more thorough. So 75 patients comparing different management. So eccentric exercises versus Shockwave versus a wait and see. So this one's just looking at one versus the other, which is good in comparison to the one before. Looking at visa scores, and they saw a decent improvement across, but it did say it showed comparable results. But I think it's one of these where individually you could say, yeah, comparable results. I think combined, I think you can get a good result as well. So it's a good idea to have a look at these. Are much lower energy, but it's very fixed at 0.1 millijoules. 2,000 impulses are pretty consistent with previous weekly treatments, again, consistent with the treatment previous as well. So just to go and look at, there's only 2 papers as an example, relatively positive, but several studies have shown that there is a better percentage of satisfactory results for non-insertional tendons rather than insertional, which I find quite an interesting conclusion from those. However, one of the limitations, and I think it was mentioned before, the variables, and we can see from the one paper that the energy is so mixed between high and low, and that we need more evidence to look at how we narrow those parameters and give us a more specific window of energy we should look at. But generally speaking, the advice is to start with lower energies and then build up to more tolerable. So quite similar to how you do eccentric loading, you start on lower loads and build up. Well, looking at those papers, we can look at 3 to 5 sessions, 1,500 to 2,500 impulses, quite a wide energy range. So it seems quite, these tendons, we know with Achilles, it can be quite reactive as well, and people's pain tolerances can be quite different. And 2 to 6 impulses per second. So not very specific, which pulls back to what our previous comment was about more study needs to be done to narrow the parameters potentially. Some papers did show negative responses for Achilles tendinopathy that I've read and that will be out there. been down to quite small sample sizes, treatment intervals of a month I've seen, and I have seen papers as well that have included insertional and non-insertional tendinopathy, which I think skews the outcome. In terms of the intervals, there's not really a consensus on what the treatment interval should be. Depends on who you speak to. Could be 3 to 5 days, could be a week, could be a couple of weeks. I think most people sit on the consensus that weekly intervals between sessions lead to better results. Sure, we'll get into a conversation at that at the end. So I have a different viewpoint on that. It depends on what you're presented with. But from the systematic reviews that I found on this subject, they show that there is satisfactory evidence for the effectiveness of low energy, so that's 0.09 millijoules and below. Anything 0.1 and above is considered high energy. But I think it's really important to note that this is in combination with eccentric loading. I think this is a common thing that we look at Shockwave on its own. I think in combination, from my practice, in combination with eccentrics, I think that's where you get the better results with patients. So just looking on to patella tendinopathy, it's a really similar thing with a couple of papers. So we know patella tendinopathy is an overuse injury affecting the knee, where there's an overstress. There's very little evidence around a protocol for appropriate management of patella tendon. But eccentric loading, as with Achilles, seems to be the first line treatment and what the first line protocol that we look at. And there are things like proliferation therapies, dry needling, some people do, PRP. There's other bits that people do, but let's look at Shockwave and how that impacts it as well. We have seen promising results with some of the papers that I've read, with success rates between 73 to 87%. So pretty strong. However, there are conflicting evidence. Shock, horror, there's always a bit of conflicting evidence with Shockwave. But again, it can be down to no evaluation to rule out calcification or partial rupture. Allowing for training during competition, we've seen that in quite a few papers. Or Shockwave being used as solitary treatment and not combined with exercise, which I think is a big part of it as well. So again, let's look at a paper just reviewed, brought it down to here. So to compare focused Shockwave and conservative treatment for patella tendon, I think these ones are much more substantial than those Achilles ones that we looked at earlier. They only had one Shockwave treatment, 1500 pulses at 0.18 millijoules, whereas the control group just looking at an exercise program with some painkillers and strapping. Looking at a pain score, but also some diagnostic ultrasound as well, and a pretty decent follow-up. And we can see a very good outcome in terms of the pain scores compared to the control, and there was a significant increase in vascularity versus control from the ultrasound aspects, and a reduction in tendon thickness, and no significant difference in the appearance between the two, but they did see some changes, and it seems to be more effective than conservative treatment in the management of chronic patella tendons. So a good positive one there, a good solid paper. Slightly smaller study, 27 patients. 3 lots treatment, 1500 pulses, a lot less energy. This is looking at it versus surgery, which it's poignant the fact we have worked with a sports club around helping avoid surgery, which we might touch on in a minute. We looked at functional outcome, Visa, VAS, Rolls and Maudsley. And there was no significant difference in VAS between the two groups. And Rolls and Maudsley scores, not much difference in that either. However, as an alternative to surgery, without really resulting in any sort of long-term changes, it could be considered an option. So I think obviously it's going to depend on your patient selection for sure. But I think it shows us positive aspects that we could be avoiding surgeries by using Shockwave, and obviously surgery means long-term changes or long-term impact. So in terms of application, looking at moderate or low intensities, especially in those wanting to avoid any surgeries. An example, 3 to 5 sessions, 1500 to 2500 impulses, 0.08 to 0.2. So not as quite a wider range as your Achilles, but similar 2 to 6 impulses per second. So quite a wide range there. As we mentioned in the first opening slides, the literature shows that it's safe to use for treating patella tendons. And we have had good positive effects with that, and I've quite clinical experience as well, very good impacts with that. And I think it is, and say from my experience with working with a particular football club, as far as I'm aware, when they had the system in, we were able to help a player avoid surgery on a patella tendon through using Shockwave and conservative management, which is a big win-win for player and club alike. However, there's a big call for understanding a little bit more about the healing mechanisms. So people want to look at colour Doppler ultrasound. I think looking at more reliable objective measures as to look at the different changes within the tissues. I don't think there's many papers that have looked at power outcomes and things like that as well, that tend to look at quite subjective outcomes. One of the interesting things, obviously, we looked at a couple of really common indications and just a couple of examples of how we could pull some of the application into, or some of the papers into an application. I thought it was pointing at this point to mention some of the other aspects I know has been researched in a couple of papers, one of which was how Shockwave can improve ACL reconstruction. And again, following this webinar, we can send out the links to these papers, so you can go find them. Or if you want to watch back on the recording, you can take a note of this. But these group looked at using Shockwave post ACL reconstruction and saw a really good response on the middle third of the tibia after the graft. I think it's quite promising from that perspective. You know, Shockwave can help support the recovery and the rehabilitation, the speed of recovery following an ACL surgery. And then what I find really interesting, and it's something it's discussed a lot in sport and also a lot of private clinics, is the application of Shockwave for meniscal tear. So there's an animal model and a rat model. They did a 2 millimeter tear into the anterior horn of the meniscus, delivered one treatment of Shockwave, and it showed full histological repair. And it stimulated proliferation in those cells. So it's quite an interesting aspect that this is an avascular area and it stimulated full repair. Now, we can take that with a pinch because obviously it's an animal model, but I think it's quite an interesting discussion, the subject to look at. If there might be some meniscal tears that are not necessarily suitable for surgeries, that Shockwave as a conservative treatment, non-invasive treatment, can help prevent surgeries or even post-surgery improve the healing of the meniscus itself. So I think it's a really interesting area, and watch this space on it really. So just to draw a couple of conclusions from that, there's a lot of information we've kind of talked through and kind of gone over some stuff pretty quickly, and we can get into a discussion in a moment. I think when we look at treatment protocols or guidelines, I like to look at things from personal perspective, is prescriptive or personalized, and look at some couple of pros and cons. I think this is quite poignant for Shockwave, is that there's an element of prescription treatment and there's an element of personalizing it. So from a prescriptive perspective, it's useful if you're new to Shockwave, you get some treatment guidelines that give you a good place to start. It's also very good for dose-dependent indications, so certain bone indications are very dose-dependent. Meniscus may go that way as well. Tendons are a little bit different, there's more variation there, but it also allows you a consistent treatment approach. From a personalized perspective, it allows you to be adaptive, and you tailor the treatment to how your patient, athlete, client is presenting and how they respond. If somebody's presenting acutely, it's going to be quite different to how you might treat them from a chronic perspective, and also what you would like to achieve from that treatment period with them. And it's also important that different tissues, tendon, ligament, bone, do respond differently to mechanical inputs. It is different from person to person, depending on age, gender, and a multitude of other things. So there's an element there. Cons to being prescriptive can be too restrictive. I think there's a risk of developing a one-size-fits-all solution. I don't think there is that. But on the other side of the coin, the personalized, there can be too much variation. And you might not be providing enough, or you could be providing too much energy. I think you can flip between the two. I personally sit on like an 80-20, as in 20% of it's prescriptive. It gives me a good start point, and then I personalize and tailor it as need be. And I think a nice balance between the two is what we would need. And looking at the research, the different variations that we have in the methods and which ones have actually been successful, there's quite a good variety out there. And I kind of look back at what we do in the gym when we're rehabbing somebody with exercise. We don't have a one size fits all. Not everybody lifts 50 kilograms. Some people could do that. Some people crash and burn at that. Depends on the stage of rehab and healing that they're at. And Shockwave is, you can apply the same things. Mechanical energy, it's all physical. So I think you can apply some of those things. If somebody's quite acute, you might want to look at lower energy levels and much more managed, maybe shorter or less energy input. Whereas more chronic, you might look at something different in comparison. But ultimately, when you come to, if you do want to look in and dive into the research, it is difficult to decipher. And I find myself, when I've read, papers, sometimes with your head against the wall, because you've read 3 or 4 papers that are either have conflicting information, or the design is not what you think could have been ideal. It's rich coming from me. I've not done papers, but I've not done any research myself. But there is a massive volume and variation, so it's quite difficult to pull out some of that information. I think what you've got to start to look for trends, and you start to see the more papers that you read and the more papers that you come across, you start to see a trend, or start to see some trends. And I think it's those ones that go against the grain, I think, are sometimes more interesting to find out, well, why did that not work? And that gives me a better idea on, okay, well, that parameter didn't work, so I might not look at that. But with this, some of the research and some of the information that you can get can be quite contradictory, and that can drive people's opinions on things, on the application of the technology in certain areas. And honestly, you could speak to me, speak to somebody else who might give us a different opinion. That can be down to what their experiences are, what system they use, what research they've read, because they could read 3 or 4 different papers to what I've read or somebody else. But it is important you take opinions on board. Obviously, you make your own decisions with things as well. Ultimately, when you look at the research that's available, the same with radial as well, we know it works, we know it's safe when used correctly and appropriately. There's a multitude of variables, I've mentioned that a few times, that we need to take into account. And I think there's, particularly with focused, as long as that focal zone that we mentioned, that little target area, is hitting the target tissue, you'll get a result. And you're going to adjust to certain parameters based on maybe experience, based on what you've read in the research. I think there's no quick and easy, right, this is your protocol. It comes with experience, but bottom line is, if you're applying it, you'll get results. It's been proven to work. So that's it. We'll stop so we can get into a bit more information, but these are all the references that I've pulled together to write this presentation, along with a couple of other papers that might be of interest. There's Achilles References and Patella References there for you. So at the back end of this, obviously, you can have these, or pause if you're watching on the webinar, and you can have a look, watching on the recording, sorry, you can have a look, and it gives you a starting point, at least, with some of this. Otherwise, thank you very much for listening. And I'm going to open Pandora's box and say, questions, anybody?
Thanks, Dom. You regret that now.
No.
No, thank you so much. That was great, informative as ever. So like Dom said, we're going to get going with some questions now. So if you haven't already, if you want to submit a question, just please use the Q&A feature, which you'll find at the bottom of your screen. So firstly, I'm going to go through some pre-submitted questions of some guys from the registration form. So thank you for submitting those. So the first few questions are surrounding the differences, Dom, between radial and focused shockwave. So I know that you mentioned this in your presentation, but to maybe answer that first question of what's the difference between radial and focused shockwave, is there anything, the main point that you would sort of answer around that one?
Yeah, I'll get the elephant out of the room of the way, the price. But there is a reason behind that. The two technologies are very different in terms of what the energies that they produce. Focused shockwave is producing a shockwave from the off. Some pressures, some radial systems build up the energy to create a shockwave, but generally speaking, it's referred to as pressure wave therapy. The energy levels with focused are considerably higher. And as I've discussed with what we kind of touched on in one of the slides, is that those different pressure waveforms have a very different impact on the tissues. So the two areas that I look at is blood flow and pain. So if you look at focus versus radial with blood, radial promotes blood flow. So it's a pro-inflammatory treatment, whereas focused stimulates angiogenesis and has been shown to stimulate new blood vessel growth. So I think that's a real definitive difference between the two. There's also evidence to show that focused shockwave has anti-inflammatory properties as well. I think it's if anybody wants to, I think it's interleukin 6 and 10. I want to say the sort of anti-inflammatory markers they have seen in the research. So they are different in that aspect. And the other aspect I like to look at is pain. So it's considered a radial, it's like an afferent barrage pain gate aspect, putting a lot of information, it kind of overrides the pain. Where there's been good evidence for focused, reduces levels of substance P and reverses growth of the C nerve fiber, the non-myelinated fiber. So you're changing pain at a physiological level. Now, there's many different thoughts and opinions on this, and it depends on the tissues that you're treating, and it depends on a multitude of things. But generally speaking, that's where we're at on things. I mean, there is very good evidence to show that the physiological impact of focused shockwave is far greater than that of radial. And we know a lot, but yet the jury's still out. We don't exactly know what it's doing. Like, it's pro-angiogenic, but then it reverses neovascularization in tendon. So how can something be pro-angiogenic but then reduce that? So there's a few things I know I need to learn a little bit more on with it, and there's a few things I know to investigate. But that's one of the main differences. And I think from an application perspective, radial is very superficial. As you showed in that diagram, hits the surface, goes out. So it's a non-specific treatment as such, beyond 3 centimeters, generally speaking. Again, depends on who you speak to. You're not going to have an impact on that tissue. Whereas focused, you get to specifically hit the target depth, bypass all the healthy tissue and just hit what you want to hit. I think that's one of the differences in the aspect with that. It's focus is a lot more comfortable for your patient, client, athlete than radial. So yeah, there's a few things. Obviously, you can get into that quite considerably, but there's just a few differences. Yeah. I will point out, by the way, it's not a radial works. I'm not saying that radial is not good. It does work, and it's a good system. It's a good technology, and it does work, particularly chronic tendons and plantar fascias and those kinds of things. It's then limited when it comes to your Achilles and some of the deeper indications. But if you're predominantly dealing with superficial tendinopathies and chronic ones at that, radial is a very good system. So I don't want to say, this is better than the other. It's just more limitations and whatever.
Yeah, of course, great. And I think you've covered as well maybe the next question then about what are the main advantages of focused shockwave over radial. So is there anything that you would want to add on that one?
It depends on what you're doing, really. Don't be waxing lyrical about, focus is great for this, focus is great for that, because it does depend on what your goal is.
Things like that, yeah.
We work with clinics that 95% of their business, 90% of their business is insurance, and seeing a lot of tendons through insurance. Now, the insurance companies don't differentiate between focused and radial. So if that's your business, again, the radial system is cheaper. The insurance companies don't differentiate between the two, so you get the same reimbursement rates. It means you're going to make a return on investment quicker, and you'll still get good results. However, if it's like, particularly with sport, we've seen a big shift recently away from radial. Radial just doesn't get that used, and particularly when focused goes in, the radial just disappears off. And I think one of the biggest things has been athlete engagement. It doesn't hurt on healthy tissue, and on problematic structures, it replicates the pain. And I've seen it time and time and time again, is when you've got a player who's got that niggly injury, whether that's football, athletics, rugby, and you replicate that pain and hit that nail on the head, the buy-in tends to be pretty instant. And it's one of the, there's people might be on this webinar watching it back, they'll have a heck of a lot more experience than me in terms of those environments. When I work in private, trying to get the patient buy-in or the athlete buy-in is probably one of the most difficult things. And as soon as you replicate the pain, it's really powerful, really, really powerful. And I think that's one of, I think, the main advantages that the one thing that I would say, yeah.
Yeah. And can you use focus shockwave with radial? Is that something that can?
So depends on who you speak to with
Right.
Now, we as PhysiQuip, we've had the opportunity to work with radial systems, and we look at the evidence, and we feel like that focus shockwave gives you more opportunity. And as a representative of PhysiQuip, we don't do radial, so if I say, oh, you don't need it, well, it's because we don't have it. So but those systems, companies that have both will say, well, you can use both. Now, if I try and come away from this, try and take the bias away from me, please. I've seen both used in practice very well. And you've got a pro-inflammatory thing that's better for, better for chronic, very good for chronic injury. Then you've got your focus you can use for acute. So if you see somebody who's 2 weeks post injury, for example, you might not be able to use radial, but your focus you could use. You could manage the pain. And I know in the elite sports setting, they're able to manage pain, keep athletes available, especially when there's no damage to tissues. The tissues are structurally sound, and they just got a little bit of niggly pain. So that's where it's really useful there. However, in the same breath, we've seen more clinics actually get a focus system, and to some degree or another, the radial almost becomes redundant, because they end up using the focus because it's more tolerable for the patient, and ultimately, if that's what the patient buys into privately as well. You could go round in roundabouts with it. I think they can be used together for sure, because there are two different waveforms that we discussed. They have two different impacts, and if you have the opportunity to get both, why not? But then I see people saying, well, if I get both, I make radial redundant. So, it's going to be it's a difficult one. It's something that we have that conversation almost every day with people we speak to. It's a very individual decision. It's very different between elite sport and private practice. And it's something that, if people want to discuss that in a little bit more detail relative to them and their businesses or their practices, then, you can obviously arrange that at some point.
Yeah. Okay, great. Perfect. So we'll move on to the next question. So what is the best parameter to change when a patient finds the shockwave treatment too painful to tolerate? Good question.
Good question, because you can play around with it. So we talk about, some people talk about intensity. I think that's just like basically how much energy you're delivering in that space of time. How intense is it? You can drop energy level, make it more tolerable. That's the easy thing, I think, or the easier, the more logical thing to do. But if you're looking at things like, I don't know, a calcific tendon, and then we've looked at the research and say, like, calcific tendon, shoulder tendinopathy, for example, your window is 0.1 to 0.3 millijoules. So, for example, on a machine that could be level 5 on the energy scale to level 10. And if your patient can't get to level 5, then what I've done as like a acclimatization is drop the frequency down to 2 or 3 shocks a second, 2-3 hertz, something like that. So it's essentially, rather than it being and absolutely hammering it, I drop it back, go or even slower. So for the client or whatever, it's just an ow, ow, ow. It's not as intense. And then we gradually build up the energy and let it acclimatize. So they get used to it. There's a conditioning, that's the word I was looking for. They get a conditioning aspect to it. And then once we get to that point, we can start to increase the frequency very, very steadily. And I think it's always look at, with this kind of thing, if you're familiar, if you do exercise rehabilitation, how do you get people to push, and how do you find what is their limit, and how do you get people up to the weights or up to the range of movement that you want them to do? You gradually build them up to it, and you might change reps. So instead of doing 20 reps off the bat, you might do 2 or 3, give it a rest, 2 or 3, give it a rest, and build it and build it and build it. It's the same thing. It's mechanical energy. So you can be quite experimental with it. But yeah, I mean, energy level is the easy one to drop off. But if you know you want to be in a window, a drop frequency, allow build the energy up, condition it at that level, and then squeeze the hertz up to the point that you want to be. And then hopefully that tends to work. I found that it works quite nicely.
Yeah, great, thank you. Next question, how is the recommended dosage, as in how many sessions and frequency, determined?
Depends. I just love that answer. I think, as I mentioned in one of the in the previous slides, is the general consensus is weekly. It depends on whether you're talking about tendon, ligament, bone. Is it acute, subacute, chronic, post-surgery, whatever? What's the extent of the injury? There's so many variables. In many elite sport settings, some do it daily for like 3 days if they've got like a chronic, but they'll manage the load. So instead of delivering 3,000 shocks, for example, or a total energy dose of, I don't know, 800 joules for plantar fascia, they might split that up in the day. So they might do 1,500 in the morning, manage them through the day, and then 1,500 in the evening, and then reassess the Tuesday morning, for example. Okay, good carryover. We'll leave it now this morning. We'll do something. We'll put another 1,000 in the afternoon, and you sort of manage those doses. That's something that people do once they become more experienced and more experimental with it. Generally speaking, if you're private practice, I work on a 3 to 5 days. It's your window. I think 7 is sometimes a little bit too long. But if it depends. Again, it depends. We had this discussion earlier today with a clinic. His weekly treatments, slightly the old-fashioned way of looking at things. Like, we'll see you next week. Yeah, we'll see you next week. We'll book you in next week. Just from practice generally, speaking to others, there seems to be more of a demand with patients. Like, they've come in with an injury, they want to get sorted. Want to get fixed as quickly as we can. And what they do at the elite level, yes, they can see them every day, but they might get treatments every 3 days. So why can we not do that in private practice? So yeah, there's that food for thought there. But I think frequency, I tend to say 3 to 5 days. 5 is fine. 7, I think, is a little bit too long. And it depends, obviously, what control you have over that patient as well, because they could go off in that 7 days. Who knows what they're doing? 3 days is the minimum to allow those physiological changes to take place, which is another, that's another conversation in terms of the physiology that we can stimulate. But 3 days is like the sort of minimum, allow those changes. And this, I'm talking general practice. Sports slightly different. Which again, kind of say that might be a conversation that we have individually with people. It's very difficult. I'm generalizing a little bit. And different environments have different demands, and you can utilize it very differently. So, short answer. I think 5 days, every 5 days, could do it within 3, 7. So I think that's kind of your window, really.
Right. All right. The last question of the pre-submitted questions then. So how much shockwave is enough? Do older tendons need less energy than, say, elite athletes?
How much shockwave is enough? Good question. Who sent that one in? So
Adam Garnett, thank you for that question.
Adam, thanks, Adam. I hope you're doing well. It's at Jersey, I think. Again, it's a difficult one because it's mechanical energy, so it's like it's difficult. I usually tend to sit on a case of if you're not seeing results within 3 sessions, and when I say results, it's quite subjective in that of what your patient is feeling is a satisfactory result. What you feel is it progressing enough? If you're not seeing it within 3 sessions, I'd be reassessing. If you're not seeing some progression within those 3 sessions, I'd be reassessing and thinking, okay, what else could be going on, or am I hitting the right spot? Is this the appropriate treatment? I've actually had a conversation with one of the football clubs that we work with. They had a player doing an Achilles tendon, and they were doing it daily, and the player started to only like 1,500, 2,000 shocks, quite low energies. And the player said I was starting to get a little bit sore. So they found the limit, and they came back away from that. So it can be quite individual, because the next player they treated was absolutely fine with some of the energy doses they were putting in. It's a very safe treatment. Not seen any, anything that says that it's detrimental or creates ruptures or anything like that. Not seen anything like that. Other people might have seen things. What was the second part of the question? Just remind me.
So how much shockwave is enough? Do older tendons need less energy than, say, elite athletes?
Older tendons, as in what? I'm going to assume older as in age older. Or age, I don't know if he means like age as in like, the patient's age 65, 70 years old, or whether it's age in terms of how long that tendon's been going on for. I'm just going to assume physical age. I think if that individual's older and they've got sort of more frail tissues, I would go on lower energies. Sure. I think it's but again, you can come across some like 50, 60 years old. I mean, my dad, for example, sorry, Dad, he's a mid-50s and he's running half marathons and marathons. He can tolerate a lot higher loads than, my father-in-law, who is not as active as that, and maybe, might not be tolerating as much. I think he's a tad older as well. So he's all right, he won't watch these recordings, so it's fine. So yeah, it's very different. I know they're relatively similar age, but their activity levels are quite different. So if you're going on physical age, it's older age, I'd go slightly less, because it might be slightly more sensitive in that sense and not as strong. So yeah, I hope that answers it.
Yeah. You've got Phil on your back now saying that 62 is not old. Thank you very much.
Sorry, Phil. I'm saying that I've only turned 30, so sorry, Phil.
Oh dear, you've got yourself in it there, Dom.
No.
All right, thank you for those pre-submitted questions. So we're just going to go through the couple which are in the Q&A section. So the first one, at what stage of recovery in shin splints is best to use focused shockwave?
Good question. I've treated it with shin splints on myself when it's been quite acute and reactive. One thing I will point out is it's not very comfortable. So again, I think if it's still quite reactive and still quite inflammatory, I'd probably be using a lot lower energy levels, like especially focused. There is anti-inflammatory aspect to it. I think it's a good aspect from a pain management perspective. So yeah, when they're sort of more acute stages, I'd be looking at lower energies and seeing how it responds. If it gets quite angry at you, or if the patient says actually that was quite sore, which I've had one or two say it was quite sore for the next couple of days. It's like, okay, it might be a bit too soon. I might look at other management options. And maybe sort of 6-week kind of mark, when it feels like it's starting to settle a little bit, it's less reactive. We've managed the patient's load. Then again, I'd start with low dose. So when I say low dose, things below 0.1 millijoules, which is going to be different for different devices in terms of what level it's on, and different therapy sources or applicators. So yeah, low doses and see how it responds, and then you build it up. But I think the stress ones are quite interesting ones, the reactive ones, same reactive tendons. Some react very positively and some get very angry at you. And I think it's also managing the patient load. So it's a nice pain management option as well. But managing the patient's load, I think, is just as well more important than in that sense. But yeah, I think anything before 4 weeks, I'd be okay. If it's still quite new, 6 to 8 weeks, I'd probably go, okay, right. If it's starting to settle, it looks like it's even managing the load and it seems to be starting to settle. If you've got something that's even more chronic, then again, I'd still just start with lower energy, see how it responds, and then build up.
Great. Perfect. Thank you. And then a question from Natalie. Thank you, Natalie. Natalie asked if is there any concerns around the use near growth plates or in conditions like patella tendons where you may have Osgood flatus, etc.
Yeah. So using Shockwave, so we call it the Shockwave entry window or the focal zone, having an epithelial disc or growth plates in that region is a contraindication. It's contraindicated, no. So from that standpoint, no. However, I know there are people treating Osgood flatus and severs, because particularly with focused Shockwave, you can control where you're delivering the energy. So if you're delivering it to the patella tendon, theoretically you're not treating the growth plate. Now, as a representative of a particular manufacturer device, it's on the absolute contraindications list, no. If you can clinically justify and prove and show that you're not treating that area and you can show there's clinical benefit, there is application. I know there's a couple of research papers that have come out looking at it, but at the moment it's still on the contraindications list. I don't think there's enough evidence yet to say whether it has detrimental effect or whether it's a positive effect at the moment, or necessarily whether it's safe to use. Initial sort of chat that I've had with people is it is safe, but me saying that is on the contraindications list. So yeah, I'd approach those ones with caution.
Okay. Yeah. And out of interest, is there much sort of studies surrounding younger patient groups or pediatrics or anything like that?
I've seen a couple on Osgood's. I mean, the younger patient ones, yeah, again, young children is a contraindication for focus or for Shockwave. I have treated with parental consent and informed consent 15-year-old, and I think there's a few more variables with children I think that come into. One is the perception of pain, it's a big one, but also the growth maturity of them. It's something we had a discussion, or we learned on a workshop recently about academy football players and how you can have two 13, 14-year-old children the same age, but their physical maturity is very different. So if it's not something that you see regularly, it's something I, again, approach with caution. I tend not to go much below 16, 17. But again, you just have your things in mind. Okay, what's their physical maturity, body maturity, where are you treating, what you're actually treating. If you're treating things like goods, whatever, I revert back to what I said before. If you're treating Achilles tendon and it's not severs or anything like that, then there could be aspects of, again, lower doses, see how it responds and build from there. Especially when those kinds of patients, there's certainly application. ACJ injuries, yeah, ATFL injuries, ligament injuries, MCL tweaks. Yeah, 16, 17, 18, you don't, not probably maybe 15-year-old. Yeah, fine, the 15-year-old we did was a tennis elbow, lateral condylitis. So, and she responded quite nicely. So, yeah, I think when you're around the growth stuff, your severs, etc., revert back to what I said, but I wouldn't go much lower than 16.
Yeah. All right, great. Thank you for that. And then a question from Stephanie. What's the rationale behind the low frequency, low intensity treatments for preventing surgery in tendinopathies?
Essentially, was it low energy?
Low frequency, low intensity treatments.
Oh, low intensity treatments. I mean, and by intensity, do you mean energy level? Do you mean so I refer to intensity of like how much energy you put in that space of time. So okay. if you put in low frequency but high energy, as in your 0.1, 0.2, 0.3 millijoules and higher, the frequency will in some cases allow you to deliver that energy without having to put your patient through the ringer. Because some patients might not be able to get to those energy levels, which, let's say for a calcific tendon in the shoulder, the window is like 0.1 to 0.3, I believe. Patella, I think, was around about the same. So the main rationale is patient tolerance. and being able to allow you to deliver the energy that we've seen in the research that has a good effect on reabsorption rates for the calcifications. In some cases, patients just might not be able to tolerate it anyway. So you might have to treat and manage the pain first, and then again build it up. And I kind of always revert back to what you do in a gym with rehab. You know, you just jump straight people. Don't jump people straight into sticking 80 kilograms on a squat rack and squatting. You might start with sit to stands or some kind of aided work before. And you build that resistance, build that tolerance. Same up. But yeah, the main reason is for dropping the intensity, dropping the frequency. Sorry, is tolerance and conditioning the tissues to allow you to deliver those higher energies where it might not be tolerable.
Yeah, great, good answer. And then lastly, I think I've covered all the questions there, and then just got a question surrounding ED, and have you come across any research surrounding this? I know this is something that we get asked a lot as well.
Around which, sorry?
ED, erectile dysfunction.
Men's health. So what's the evidence behind it?
Have you come across any research? But if you'd like to just sort of...
Yeah. Oh, I mean, there's stacks. There's actually some really good evidence behind vascular ED. Peroni's a bit mixed. The vascular ED aspect is positive. It's promoting angiogenesis, new blood flow into the region. That's why I say vascular aspect. The men's health is an interesting subject. There's a lot of MSK practices looking into this, because it's a very simple, non-invasive treatment option. You don't have to have your medications. Your medications just treat the symptom, not the problem. And for things, done a little bit of work in this area in terms of one of the pushbacks with patients is it just takes away the spontaneity of things. Like I say, it's just treating the symptom. It's not treating the actual problem. You've got invasive options, which not many people are fans of, understandably. So Focus Shockwave is actually on the, I think it's the British Association of Urology site, or one of the urology societies, the European Urology Society, I think it is, as a first-line treatment for vascular ED. So it is recommended as first-line treatment. It's non-invasive. Treatment packages tend to be 6 to 8 treatments within about 4 weeks, 4 to 6 weeks. So it's a really clear, concise thing. I mean, the evidence, we can say, whoever's asked, if anybody's asking, we can send over the evidence, but it's there. It's still developing, for sure. And I think it's an area of hot topics. I think it's quite divisive in terms of opinions on it. Some people say it works. Some people are like, not so sure. I think it ultimately comes down to patient selection. It's kind of the same with bone. Bone indications are very, very positive, 60 to 80% success rates based on the papers, but I think it comes down to massively selecting the right patients and making sure they're appropriate. It doesn't work for all. Same with mental health. We do have an algorithm specific to the piezo system that can help you determine whether there is an appropriate patient or not. But yeah, I think with patient selection, you will get there.
Yeah,
they'll be happy.
Great, thank you. I've got a last minute submission from John. His question is, what sort of energy is required for bone non-unions and frequency of treatments, please?
So with bone non-unions, did you say?
Yeah.
Okay. Depends on the size of the bone. Generally, the smaller the bone, the lower the energy. The bigger the bone, the higher the energy. Much higher doses they are in terms of the amount of shocks. So you're looking at sort of 6,000 to 8,000 shocks. Frequencies, I think it tends to be, it's like 5 to 7 days on those. If I remember off the top of my head, I might need to just revise that, but it's usually 5 to 7 days on non-unions. Obviously, class of non-union, if you've obviously done x-rays or even scans and you're not seeing any calcification, you class that as a non-union. I know from experience, I had an avulsion fracture on my ankle, which was, 3 months and didn't show any kind of signs of healing. We did 4 treatments in weekly sessions on that. And then it started to show healing. And then that was it. And after that, I think another 4 weeks or so, it was all good. But they were quite low energy doses. sort of 0.1 to 0.3-ish. We have the option of going up to 0.7, 0.8. So it was quite low in terms of what the range that we had available to us. But yeah, generally, the smaller the bone, the lower the energy, the bigger the bone, the higher the energy input.
Great. Thank you very much. So I think that sums up all the questions there we've got. So thank you very much for all those. So I hope everyone found that useful, and thank you for those who've joined us. And thank you, Dom, for your time and your Shockwave knowledge. Obviously, these sessions are really helpful. I'm glad that we can keep doing them. So following this session, you'll be prompted to fill out some feedback. So we'd really appreciate any feedback and suggestions for future webinars. And as of tomorrow, this webinar will sit on our Physical Academy site, alongside all our previous webinars and other educational resources, including the upper limb version of Translating Research to Practice that Don mentioned that we did last year. So the Academy site is very new and pretty, so please go and check it out because it does look very good. Otherwise, if you have any further questions or if you want to find out any more about our products or educational events, just please feel free to reach out to us, info@physequip.com. So thank you again. Thanks, Dom.
No problem. And just to add to that, I mentioned before is that if people want to have any conversations, if you're watching the recording as well on this, and you do want to have a more detailed conversation with myself or anybody in our network about how you could apply Shockwave specific to your setting, then more than happy to book a call in on Teams or whichever to discuss in a little bit more detail. Always happy to help.
Yeah, absolutely. So thank you again, and I hope everyone has a good rest of the evening.
Thanks. Cheers.
Bye.